So we have the role of N-acetylcysteine and taurine in reducing microalbuminuria. So this is from the latest evidence it was published in Kidney International in 2025. So I call upon, I think, Dr. Ashwin Karuppan from Chennai. Welcome, sir. I think I'll hand over to Dr. Radhika for the introduction.
Dr. Ashwin Karuppan is Chairman and Medical Director, Trivandrum Medical Center and Research Institute, Chennai. He is also HOD and Senior Consultant, Gleneagles Health City, Chennai. He is a Course Director for DNP Medicine and Associate Professor. He is the founder of Trivandrum Medical Foundation, which has initiated dialysis sessions, including many free dialysis. Over to you, Dr. Ashwin.
A very good afternoon to one and all. Thank you, Chairpersons. As Dr. Praveen has already said that there has been various contradictions, even not only for the diabetologist and the nephrologist. I always believe that as a physician, we continue to learn based on the evidence which are available. So this is one such talks which I have given for various forums. And I'm basically a transitional scientist or a researcher where I try to link the basics along with the clinical practice. So that's how we entered into this. So role of NAC and Taurine in reducing microalbuminuria. What are the latest evidences? If you can see in the background, the chronic kidney diseases, it always is a progressive chronic kidney disease. We are all well aware of how it progresses. Whatever you do, whatever medication so far we have given, we have not seen a reversal of any chronic kidney diseases, but it continues to progress on and on. So most of the time I tell my patients that your baseline is reset. So we need to continue, this is going to keep on increasing, the creatinine is going to keep on increasing, and the only way to control your blood sugars from the time I have learned medicine is by good control of the comorbid factors, which includes diabetes and hypertension. So ultimately the patient reaches a goal where it goes to stage 5 and stage 6. That depends upon various other factors. But if you see in 2012 KDIGO guideline classification, there is an important addition. Apart from the eGFR, which has basically been calculated, we also started naming it based on albuminuria. We did A1, A2, A3. We added this to G1, G2, and so on. And that's how in 2012 we got these classifications. And now all diabetologists, physicians, and no matter where you practice, microalbuminuria has been a part of regular screening every 6 months to 1 year once, and we always see that it keeps increasing, decreasing based on the drugs which they use. When you come to diabetes, you see various factors. It is not a single factor which actually plays a role in diabetic chronic kidney diseases, but it has metabolic disturbances, hemodynamic disturbances, and inflammation, which forms the crust or the basic standard treatment which we are trying to fix today. And recently, yesterday today I got an update on ADA where they have clearly indicated what are the 4 pillars for treating chronic kidney diseases, and there is nothing to contest on that. That is the standard line of care. So when you come to metabolic disturbances, others you have the reactive oxygen species, one of the most common factor which plays a vital role in most of these. And then you have the gut hormone changes, which now probiotics playing a major role, and there are many studies which are going on in the probiotics. And then you have the angiotensin, aldosterone, and then you come to the MR overactivation, thereby producing advanced glycolated end products, and then so on. You keep going on, and then you see the inflammatory factors. Ultimately, all this leads to one single factor where you have the extracellular matrix expansion, and then you go to the glomerular sclerosis and tubointerstitial inflammation and fibrosis. That is the basic pathophysiology of the whole downstream. So, talking about this interesting molecule about N-acetylcysteine. N-acetylcysteine has found to be in use for quite a long time. It's a direct scavenger of free radicals. It's an antioxidant, decreases serum creatinine, lowers albumin, and improves kidney function, relieves inflammation and reduces cardiovascular events, not only on the kidneys but also on the liver and other parameters. We commonly use this in clinical practice for paracetamol poisoning, and apart from which, even for contrast-induced nephropathy, in 2006 we have a paper which has been published in NEJM which says that creatinine increases by 25% in most of these patients who undergo angiogram, and still continues to be in practice that whenever we see these patients and when people who undergo angiograms, even the cardiologists, I have seen them using N-acetylcysteine in most of these patients. In the retrospective study, or if you see that's published in European Journal of Internal Medicine in 2017, about 1.2 lakh patients who are chronic kidney disease were followed up for 10 years, and they found out patients who were using N-acetylcysteine found out to be association of 18% reduction of risk in end-stage renal failure. Similarly, an article which was published in 2023, you can see that it reduces CKD progression, and a 3-year retrospective study, also the incidence of hemodialysis was significantly reduced in patients who are using these drugs. And coming to the taurine. Taurine is a non-essential amino acid which plays a vital role, especially in all the kidney vasculatures. It's the vasculature, it regulates the blood flow. Glomerular, it's a free oxygen species radical, a scavenger, and then in proximal tubule it is a sodium transporter, regulated taurine body pool, osmoregulations, and cell volume degradation. These are the roles of normally in taurine, and what happens in chronic kidney diseases is taurine is lost from the body. So there is a depletion of taurine in most of these patients, and that can reduce to a lot of problems when it comes to renal blood flow, ischemia, perfusion, antioxidant properties, and a lot of others. So, when you come to chronic kidney diseases, the major factor looks like it's an antioxidant versus oxygen-free radicals which neutralizes, which causes oxidative stress. And the combination of these two drugs actually prevent this oxidation stress to a certain extent, where tissue injury, inflammation, and apoptosis has been reduced. And that is what has been the pathophysiology of how this drug seems to be working. So it protects the glomerular basement membrane and thereby the podocytes. And then coming to what evidence do we have? See, previously this drug has been there nearly for 20 years in most of the practice. And I still have a lot of nephrologists who disagrees with this kind of treatment, or for that matter any non-nutraceuticals. I have worked in various setups across the country, and then I have seen that yes, whatever they say also looks right to me, because everyone has a different perspective of what they do. But then here comes a certain studies which might go into further evidence where it is slowly developing, and these are a single center arm study, and it was 6 nephrologist center study, and then the diabetologist. If you can see, this one was published in KI reports in Kidney International in 2025, which is very recent. It is a prospective study, multicentral, double-blinded, and then it was also supplementation of N-acetylcysteine and taurine in preventing progression of CKD. They found out to have a 34% reduction in microalbuminuria. And these are the nephrologists who have been involved in these studies. And I should agree that I have not met any of them so far. So from this, what these studies, the 3 parameters which was measured, that is the microalbumin, serum creatinine, and cystatin C, they can see that the result shows that overall urine albumin creatinine ratio declined by 18.6% in the NAC group, and there was a 34% reduction in microalbuminuria and 17.55% reduction in macroalbuminuria in most of these patients. And similarly, the overall cystatin C reduced by 21.89% in the NAC group compared to placebo, and the median range from baseline to these studies and between the two groups were also statistically significant. So when you come to the eGFR also, the group which had the NAC and Taurine with low protein diet seems to help in the preservation of eGFR after 6 months of treatment. And there was, the group also showed 1.32 ml per a minute greater increased in EGFR compared to that of placebo in stage 3. And it seems to have been very effective, especially when you used in early stages of CKD, especially in stage 1 and stage 2. Coming to the overall summary of this particular trial, which was being published, 18.6% overall reduction in urine albumin creatinine ratio was seen. And then the cystatin also reduced by 21.89%. And we can see after 6 months, still the EFR, at least it did not deteriorate, it was continued to be preserved when it was used with a low protein diet. Similarly, this study was published back in 2008, where you can see this was the initial pilot study where 41 patients were treated with a similar drug. And then along with ACE and ARBs, we back then we knew in 2018 that we also used ACE and ARBs, but then when the creatinine started to rise, most of the time we withdraw this drug. And today we have a very clear-cut indication that ACE and ARBs are the first drug of choice for patients who have chronic kidney diseases. And then it depends upon how the creatinine doubles up and triples up, you need to stop it. So this was the first initial study which was published back in 2008 by Dr. Vijay Vishwanathan, who is the current president of the RSSDI. So coming to the study which I was involved, a part of it was done by me in my center. This was published in the World Journal for Pharmaceuticals Research and Therapeutics in 2025. This was a retrospective analysis where Dr. V. Mohan actually headed this study, and I was a part of this study from Chennai, and there are other various people. There was approximately around 305 patients, and what we did is we just substituted to the standard of care. We substituted these drugs to these patients, and then we studied these after 3 to 6 months to find out what happened. The overall reduction in UACR, we found out that it was 11.77% after 90 days. And the UACR reduction was much better when you used in the stage 1 and stage 2 CKD compared to stage 3. And in stage 4 and 5, there are no role for such drugs. And coming to the summary, we found out that there was 11.77% within 3 months in these patients, especially when it used in early, in patients who had diabetes, kidney diseases, or are hypertensive. The stage 1, reduction was found out to be much better when compared to the last stages, which is stage 3, after which we did not try it on stage 4 and stage 5 in these patients because there are no roles for any drugs in those conditions. So to summarize the whole studies as per NAC and Taurine can be considered as an adjuvant therapy in these patients based on your clinical practice, and the benefit was significant. Microalbumin reduction have been seen in our studies, and the start of NAC and Taurine, especially between the stage 1 and 2, is very crucial because after that it might not have much of a role. And NAC and Taurine benefits are better in diabetic patients when compared to microalbuminuria. So if you come to the effective of pyridoxamine, especially with low protein diet, published in JPEF in 2022, a similar study was also found in that there was a preservation of EGFR in most of this. So there are multiple evidence which are building, which will continue to be there because we are desperately looking for some products which can actually help out in reversing these conditions, or if not, at least preserving the nephrons and the kidneys. So the standard of care doesn't have any changes at all. The standard of care is SGLT2 in diabetic patients, ACE and ARBs, in hypertensive patients, inflammation and fibrosis. Yes, mineralocorticoid agonists have a role, and GLP-1 continues to rule, and today GLP-1s are affordable, and it is also most advanced in many of these patients. So as an adjuvant therapy for reactive oxygen species, it can be considered depending upon your clinical practice and your experience, because everyone has a different kind of experience. And just to be on the on giving a note, all these patients who had these reduction of microalbuminuria were on standard of care. So there was no isolated evidence where you have only N-acetylcysteine and taurine given to these patients, and then probably the trial was made. So along with standard of care, this can be used based on your practice. So thank you for the patient listening, and I think I have come to the end of it. I'm very eager and anxious to hear from Dr. Praveen and Dr. Radhika.
Yeah, actually, it is a very, very controversial topic, because as a nephrologist, I don't use this molecule, to be frank, because the evidence is, unfortunately, you have presented the evidence, but that is very poor quality evidence in terms of, we look at it in the standard pillars of care. If you take, this is the ACE inhibitor ARB, we had the large trials, the IDNT, the renal trial, the SGLT2 trials, we had so many trials, cadence and all the others. We have renal trials, which are all trials which happen over a period of say 3 to 4 years and is properly randomized, done in multiple centers all over the world. And the two studies that are presented, one of them from the Kidney International, is actually a World Congress of Nephrology paper which was sent by the team from Delhi, which I know. And they don't even mention how many patients, and it's a very small duration, and I don't think we should take any message from that trial per se to start patients on N-acetylcysteine, because even for patients with contrast-induced nephropathy, there have been meta-analysis and meta-analysis of meta-analysis which have shown that N-acetylcysteine really does not work much, even though it has antioxidant properties in terms of protecting kidneys from the contrast damage. And the first study that we mentioned from Dr. Vishwanathan, I had gone through that paper. It is actually from 2008. It was only 41 patients, and it was actually a 3-month trial. I don't think 3 months or 6 months you can really make a difference in terms of how much of renal GFR changes can be made. And I don't think we should be projecting this as a molecule in addition to, and put it in the middle of SGLT2 and finerenone on one side and ACE inhibitor and ARB on the other side. So I believe this is something that probably needs more research. That is what is, because we don't have any strong randomized controlled trials. And I would hand over to Radhika for her opinion on this. This is my opinion. I'm not against the molecule. I'm saying that there has to be research. There has to be a proper research before, because people are paying for this molecule, right?
Correct.
So we should have solid evidence before we actually say that this molecule is good.
I completely agree with Dr. Praveen. I think that at this point, the evidence is very weak. We don't have any strong studies which is like long-term, because when we say that something can retard the progression of chronic kidney disease, we need long-term studies which actually show that the GFR fall has been retarded, as has been shown by our SGLT2 inhibitors or finerenone and ACE ARBs. Many studies are there to support them. So this molecule, it might work, but unfortunately, I don't know why. There have not been many studies, and most of the studies that we just saw also have been like 3 months, and it is very short duration, and most of them have looked at only at a short-term reduction of albumin-creatinine ratio. We have not actually seen an effect on the GFR per se. So unless the GFR is, the reduction in the slope of the GFR is affected, actually doesn't matter, like whether you reduce the proteinuria in the short term or not. And also, if you see most of the studies, this drug, even though it is being given along with standard of care, this drug has been added to a low-protein diet as well.
Correct.
Low-protein diet per se has been known very well to reduce the retard the progression of CKD, but we don't routinely advise it to our patients because already our patients are on a low-protein diet. So, with only this drug and not on a low-protein diet, how will this affect is again a confounding factor. So, definitely we need more studies before we can actually put it in our prescription. But yes, we see this drug in many prescriptions. So as of now, I would say the evidence is poor.
Thank you for Chairpersons for this insight. And I do agree that there is no evidence much. But then I have only come here to present my study of what we have seen in our centers. So apart from that, if you see, the standard of care doesn't changes in anything. For even the diet pattern. Even if you see, we talk about weight is over, so weight reduction drugs have come into place. But the standard lifestyle protocol and the diet changes continues to apply in all of us. So there are some controversies where low protein diet, especially in Indian population, where they are sarcopenic. So how does the low protein diet actually affect the patients most of the time? So we don't know whether to prescribe them the low protein diet where they are already sarcopenic, or to prescribe them with high protein diet where it progresses on the CKD font.
No, I'm not saying that we should prescribe a low protein diet. I said in the study, this
Correct.
drug has been prescribed along with a low protein diet.
Yes, so that is why I said
We never prescribe a low protein diet to any of our patients because of the reasons you said. They are already sarcopenic, already an Indian diet is low on protein. So we usually don't.
Yes, so probably we need more evidence, we need more trials. But then what I believe in, whenever I do a research on these products, I always believe that the absence of evidence doesn't signify evidence of absence. So we need more and more of this. Trial needs to be done aloof. And I do agree that it is too early for us to recommend this as a standard of care. But then as an adjuvant therapy, we continue to use these molecules for the last 10-15 years.
Should always take these molecules as the pinch of salt in terms of whether we should use or not, because what happens really is that when patient has a creatinine rise of say 1.2 to 1.3, 1.4, they start taking this molecule. They don't really evaluate as to what is the cause of CKD. That is one group. Second is they, instead of taking a standard molecule which is advised by all this international sort of recommendations, they stop, they don't take an SGLT2 inhibitor or an ACE inhibitor ARB and they take this molecule. That is another problem. The third problem is many people start taking this at the end of their sort of the kidney life, stage 3, stage 4, stage 5 CKD, where absolutely nothing can be done. And they hope that something will happen to their kidney and it will improve. And they don't do dialysis and they don't go for transplants and all. And unfortunately, it is a bad outcome for the patient. So, Dr. Ashwin, I think we don't have much time. So, I congratulate you for coming here and presenting this data to us. It is basically a call to all of us to actually do good research, do randomized controlled trials, not be just be focusing on what a pharma company basically pushes us to do. So let us hope more data comes on this molecule. Thank you.
Thank you. Thank you.